purely speaking about techniques in pelvic fixation. So, as most of us know, they're extremely high energy injuries and have a lot of associated number and variety of associated traumas. You can have other extremity injuries, visceral injuries associated. Typically, in such situations in trauma, we can never forget ATLS, and so that has to be stuck to, primary and secondary survey and follow the protocol. The goals of, fixation of pelvic fractures or pelvic injuries, first and foremost, is to, make a diagnosis of mechanical instability. That's very, very important. Then after that, we have to pick up hemodynamic instability, because mechanical instability usually is associated with dynamic instability. Yes. Okay. And the other thing is that you have to diagnose open pelvic injuries, because we're dealing with life-threatening problems. And after you pick up open pelvic injuries, very key is to do a good debridement and a diverting colostomy. One of the things we've come to realize is that, sometimes it's not so much about the location of the injury, it's the degree of displacement. Like, in this image, as you can see, there's a disruption of the sacrum, and because of the degree of displacement, you're likely to have neurologic injury, like in this patient who had L2 to L4 fallout. Morel-Lavalley lesions should not be forgotten. A good number of them get infected if they are not picked up. So they always require a debridement, which can be done staged or can be done at the time of the definitive fixation. A good example is this one, a huge one, very obvious. You can be able to pick it up, open it up and drain it. But sometimes they are subtle, and you have to have an aerial view of both, hips. And so when you look, you can see what I usually call an unequal buttock or an equal, hip. This side, you can see there's a mound, here it's flat. And this patient actually had a very bad injury. He had both a subcutaneous and subfascial degloving. So actually ended up needing debridement and actually ended up 2 drains. Both one is subcutaneous, one deep in the fascia. The other thing to always remember in the pelvis, very, very key, is a third of patients have got what we call a dysmorphic pelvis. It's a problem of segmentation, what people have called lumbosacral segmentation problems, and have all different classifications. The importance of this is very key, is because if at all you're going to be putting a screw, this is the SI joint right in here. If you're going to be putting a screw across for this normal pelvis, it's very easy to have a corridor across. But for this one, because of the dysmorphism, you can see the way they are sloping on the 3D, right on either side. Okay, so if you're trying to put a sacroiliac screw across, you can see you're not able to go directly across. You're putting like a transacral screw. You'll end up in the foramina. And so you actually have to only put, you'll be forced to use almost like navigation or S2 screw to be able to, stabilize those sacroiliac joints. It's because of how they are slanted. So it's always good to remember that. And that's very important. We're going to look at it in a short while. I'm going to talk a little bit about percutaneous techniques, a good number of them. And that's where everything is going, and that's very important. Traditional methods of fixation have always been, using, big plates, sacral bars, plating the SI joints, but things have changed. Why? Because all those methods are associated, have disadvantages. You do too much dissections, you have prominent implants, you bleed a lot, and also you end up with infection. If you look at all those complications, most of them are due to the exposure, the surgery itself. So can we improve that by improving the surgical technique? And that's why percutaneous techniques now, are becoming better, because they have less bleeding, less risk of infection, and you have early return to activity. As we work in the pelvis, we have to remember the real estate is very, very expensive, and that's very important. So many visceral organs, we have got neurovascular structures, and so it's good to understand the anatomy very, very well before you delve in there. So let's start. So you have radiographic evaluation. We have our usual X-rays. AP pelvis, you have an inlet and outlet view. And also, remember, when you're dealing with the pelvis, always remember contrast studies, and that is the cystourethrogram. And then now, very, very key, if you X-ray the pelvis, by and large, if you have a fracture, for me, it's a rule. You always have to have a CT scan for you to be able to see well. This is, a cartoon, basically having a representation of what is an inlet view. So you have the beam coming in that direction, and so you're able to see from the top, okay? And then this is the outlet view. So the beam comes from the caudal, towards the cephalad position, and you're able to see the sacrum quite well facing you. So like that is S1, S1, S2, and that is S2. And also you're able to see the anterior column right in there. Okay, let's now start, going into, cases, and I'll use the Young and Burgess classification to be able to stratify my cases so that you can look at each, one by one. So we have got lateral compression injuries, anterior-posterior compression, and also we have got vertical shear. I'll mainly dwell with the lateral compression and anterior-posterior compression in the interest of time. So in lateral compression type 1, usually anteriorly you have superior and inferior pubic rami fractures or symphysis disruption, and posteriorly usually there's compression of the sacrum, usually on the same side, but it can be contralateral. LC type 2, you have an LC type 1 injury anteriorly, that is the rami fractures, and posteriorly you have a crescent fracture of the ilium. So let's start with the lateral compression type 1. You have a sacral fracture right in there through the sacrum, and on the lateral side you have got a superior pubic rami fracture and inferior pubic rami fracture. How are we going, to take care of the sacral fracture? It is through the SI or the sacroiliac screw, what you can call an iliosacral screw. This is a very important landmark that somebody has to understand for you to be able to successfully be able to deploy a sacroiliac screw or an iliosacral screw. And that is the iliacortical density. The iliacortical density, initially it was described by a gentleman called Chief Prout and his colleagues. And the iliacortical density is this black line. This black line, it represents the iliac portion of the sacroiliac joint. So as long as you're just below it or touching it, and you're not anterior here, and you're not posterior into the spinal canal, then you're within a safe zone. So very, very important to remember that. It gives you a nice starting point. So that's very, very, very key. So it keeps you within the ilium, and then you never get out to go and hit L5 nerve root. And so after it gives you a starting point, the iliacortical density, and so it allows you to do the patient when he's supine. And then now you go to the outlet and inlet views. One, for the outlet view, to ensure you are above S1, which is right in there, okay? And here, in the inlet view, to ensure you don't come anteriorly here to hit L5, which sits right in here, and then you don't go into the spinal canal right in there. So I usually use a flexible drill bit for starters, and then I change it into a guide wire. So there, the screw has been deployed, showing us it's a 7.3 screw. That's the inlet view, that's the outlet view. So it's within the bone, and here it is above the S1, which is right here. Very important. First case, 35-year-old male. He was post-road traffic accident, and you can see he has got an LC type 1. He has got here, he's got a fracture right in there, he has got a fracture there. But when you look at it from the top, it's both sides actually. Yes, it's quite comminuted, okay? And also he has got this anterior sphenic spine avulsion. It was several weeks out, so it was quite a challenge to go in and reconstruct it. But before that, let's introduce a very important concept, and that is being able to sit down at your CT scan place and be able to understand what is known as multiplanar reconstruction. So it's a very nice tool that actually is provided in the CT scan, or if you are having a PAC system, picture archiving classification system, you should be able to go in and be able to draw lines, these two blue and green lines, with simultaneously. You have an axial cut, coronal cut, and a sagittal cut. So you're able to move such in a way that you're able to move this green line, and it moves simultaneously here in a way that you're able to get the exact spot where you want to put in your screw. And for example, like if I've chosen, I'm going to put in my screw through here in the sagittal plane, automatically these these lines will be able to show me where am I passing in view of the S1 in the coronal image, and here in view of whether I'm going to go into the spinal canal or going anteriorly to hit L5 in this axial cut. So it's a very nice thing, multiplanar reconstruction. So this is planning for S1, and this on this other side is planning for S2. And you can see like this patient, the fracture actually exited way next to S2. So it was quite an unstable fracture. And so after doing that, very happy, patient has no sacral dysmorphism, done good planning, went in anteriorly, used 3.5 millimeter recon locking plates to fix the anterior fractures, and then deployed a screw, sacroiliac screw posteriorly. So there is the screw deployed, showing us in the outlet view and also on the lateral view that's within the bone. Always remember the tip of the screw has to be within S1 to be able to be sure that you are safe. It's not going posteriorly into the spinal canal and not coming anteriorly. Always look at the tip. Your starting point, which shows the washer, can be anywhere, but your tip of screw has to be somewhere there. And most of the body of it. Remember that, the body of it. So the head can be here, the head can be here, but the tip and most of the body has to be within S1. 38-year-old male, post-road traffic accident. Looking at the X-ray, the reason I put this X-ray here, it looks very innocuous, but it belies about. You know, when you look at the CT scan, you can see here, what we were not seeing at the back here, all of a sudden we can be able to see, you know, a fracture in the sacrum at the back right in there. And, you know, you look at it furthermore, you can see there is a fracture there, and a fracture there, and a fracture there. So it's a patient who is likely actually to end up with, actually was having a lot of pain, is likely to end up with displacement. So percutaneous techniques, very easy to fix, went in anteriorly, through financial incision, found bruised abdominal wall content structures, and went in and put in a locking plate, and then put in an iliosacral screw posteriorly. Inlet view, there it is, and outlet, and the lateral view showing a successful deployment of the screw. This gentleman was very interesting. He already had, before the injury, because it's a truck that fell on him when he was underneath trying to change the tire. His sacroiliac joints, both of them were actually synostused, this side and that side. So his failure was through here, through the left side. You can see that. And then anteriorly, superior and inferior pelvic rami. So it decided is a 54-year-old gentleman, don't want to do so much dissection, there's no much displacement, so ended up doing everything percutaneous. And so put in a iliosacral screw, and through then both superior and inferior pelvic rami deployed two 7.3 screws. At times it's challenging to put 7.3 screws. So remember, I've gone in and I've blown off part of this fracture, fracture fragment. So you can actually elect to put 6.5 or 5.5 screws if you have them. So here he is, he's healing quite well, ambulant, and has no pain. Lateral compression type 2 is a very interesting one. It's through the iliac wing, and can be through the iliac wing, can be anterior to the sacroiliac joint, according to Day classification type 1, anteriorly, can be right through the center of the sacroiliac joint, or can be way at the back there. So Day 2 and Day 3 actually can be fixed in the same way by deploying this iliosacral screw only. You don't need this screw right in here. For Day type 1, it's very interesting. So the sacroiliac joint usually is intact, but the fracture is through here. So you deploy a screw from the front. Sorry, this pictorial representation, I don't use this type of screw. It's actually from the front, as you're going to see. And you can actually put it through the sciatic buttress. An example is this one. 26-year-old gentleman, road traffic accident, and he had got a head injury and hemothorax. You can see there's an iliac wing fracture there and a fracture right through the front. So how do you stabilize this? Because this is where the main stability is. There is his pneumocephalus, and here he has got a hemothorax. You go to the technique of percutaneous sciatic buttress screw. So there are several views which I want to emphasize today. And the first one is what is called the outlet obturator oblique. So this is a skeleton, the pelvis is facing up. So this is an outlet view. And then you try and swing the cm to be able to come and see the obturator foramen and face. And so you have an outlet view and obturator, and it will show you what is called the flame sign or the teardrop sign. And here it is. And here are the two guide wires that have been deployed. So that gives you a starting point. But then how do you know you're above the sciatic, greater sciatic notch, so that you don't hit the sciatic nerve? It is using the iliac oblique view. You can see the guide wire is there, and this is the greater sciatic notch. Exactly. So it's very, very important to ensure you are above that. And then how do you know you're between the two cortices of the ilium? You do what is called the rollover view, or the inlet coaxial view. So you do an inlet, and then you swing the cm towards to the top actually of the ilium, so that you can look at it from the top, what we call a coaxial view. And you can see the guide wire is here, the fracture is through here, So this is the sacroiliac joint. So this is the inner table of the ilium. This is the outer table of the ilium, and the guide wire is going in that direction. Let's look at an example. This is for that patient. This is the teardrop on the obturator outlet view. You can see the teardrop, and then this is the rollover view showing the ilium from the top, right in there. So the screw should actually pass through right through here. And there it is. The screw has been deployed right through between this cortex and this cortex. And then looking at it in the iliac oblique view, it's above the greater sciatic notch. And then finally, you can see the screw with a nice bullseye showing you the cannulation. 31-year-old male, post-road traffic accident. He had got this day type 1, and here it is. You can see most of it is anterior, so it's bringing these fragments together. And you can see, used this one here, this pin, as a joystick, and then this is the guide wire going into the sciatic buttress. And so ended up deploying the screw, which is around 125, can go to 130, depending on how big the person's pelvis is. And you can see you end up using a 2 to 3 centimeter incision to be able to deploy that screw. So there he is. We did not put a screw into the anterior column, so the X-ray is of poor quality, but you can see it is not displaced further and is healed quite well. Day type 2 usually is through the center of the sacroiliac joint. So the main thing is to bring this fragment to the sacrum. So that's very important. So you can actually put in a screw from the ilium to the sacrum. And so that's looking at it in the 3D reconstruction, you can see the sacroiliac joint is disrupted here and the fracture is at the back. So bring this to that and also fix the front. So we started by fixing the front so it can help reduce whatever is at the back, very important. And then was using this pin here in the supraacetabular region as a joystick to help us reduce the fracture in front and at the back, and then deployed the iliosacral screw. Very important. LC type 3 is actually an LC type 1 or 2, but on the contralateral side, you have got an anteroposterior compression. That is the diastasis of the sacroiliac joint in the symphysis. So usually it's because of a rollover mechanism, and that's why you injure one side and it goes further to injure the other side. So it's like what we call a windswept pelvis. So you injure this side and the force vector goes over and opens the other side. So that's an LC type 3. An example here, as you can see, the X-ray, initially when the patient arrived in casualty, had this kind of injury. You can see the symphysis pubis is opened up. Here the sacroiliac joint is opened up. And this side, he had a sacral fracture, which is very subtle, which when you do the CT scan, actually shows you that even he had got a combination of a buckle of the sacrum, that is LC type 1, and an LC type 2, and on the other side, he had an LC type 3. He came in and he had a pelvic binder applied. So when you look at the symphysis pubis, it looks very okay on this 3D when you're looking at it from the top, from the front. When you look at it from the top, you can see they are not equal. So actually the X-ray was actually helping us to complement the CT scan. When they did the multiplanar reconstruction planning and fixed the front, first fixed this fracture here, and then joined the symphysis. And at the back, because both sacroiliac joints had disruptions, one in the sacrum side and one at the sacroiliac joint portion, ended up with 2 sacroiliac screws. What about APC? APC, anteroposterior compression, usually there are spaces anteriorly through the symphysis pubis, and then you have variable disruption at the back, which will determine, depending on the amount of disruption at the back, determine whether it's APC 1, 2, or 3. So 1 usually is the innocuous one, which usually most of the time, as it is, you don't have so much disruption at the back, and so you can actually end up not doing anything about it. APC type 1, so actually can be let alone. But APC type 2 is where the problem is, because you think about the pelvis as an osteoligamental structure. APC type 2 has most of the time sacrotuberous, sacrospinous ligaments are disrupted, and anterior sacroiliac joint ligaments are disrupted. APC type 3, you have a complete SI joint disruption. So APC type 2 and 3, they need to be fixed. So APC type 2 example is this one. Patient came in, had a combined, has a acetabular fracture, and has 2 SI joint disruptions at the back. You know, as you can see on this axial cut, the APC type 2 anterior sacroiliac ligaments are disrupted, at the back they're intact. So what did you elect to do? You close the book from the front and fix at the back, and also had an acetabular reconstruction. So very, very important. So APC type 3, you have got complete disruption of the posterior of the sacroiliac ligaments, both anterior, interossei, and also posterior sacroiliac ligaments. This patient had some degree of sacral dysmorphism. You can see the sacrum here is sloping on either side. But went in and looked at the multiplanar reconstruction and planned very well, and realized can be able actually to sneak in as sacroiliac screws without actually getting into any nerve or injuring it. So what did he do? Went into the front, closed the book from the front, and deployed, because of the degree of instability of APC type 3, deployed both an S1 and an S2 screw. You can see there is the S1 neuroforamina. I also will jump directly, because in the interest of time, to combined injuries. You can have combined vectors. Occasionally, occasionally you have two separate injuries. You have, like, example, like you have somebody sitting astride on a motorbike. He's ejected. So basically, when his legs are astride, impact opens up, then he lands on the side. So you have an APC and lateral compression, and you can also have an anteroposterior compression and vertical shear. So that's an pictorial representation. So here is an example. This gentleman who had actually an APC disruption, landed on the side and broke his ilium right in there. As you can see, he's disrupted in front, and also here at the back is broken. You know, he has got this disruption. He had a huge Morel Lavalley lesion, and this showing you at the back the V type of injury. So the issue is, how do you best approach this? The first thing is get what is easiest to reduce, and that is first reduce the symphysis pubis. So reduce that very well, get a good reduction, helps you reduce the rest. And then went in and deployed a sciatic buttress screw from anterior to posterior, and then we were able actually to use a long screw. We were very lucky to have it. It was around 123.5 screw, and fix that iliac wing triangular fragment. And this gentleman actually ended up doing quite well, and we were able to clean out the Morel Lavalley lesion. Here is another patient actually who had lateral compression and vertical shear. She actually, as you can see, there is disruption at the back and displacement posteriorly of the sacrum through the neuroforamina, and these two fractures here quite displaced. So went in and it was a little bit late. Actually, when she came in, she was brought in because they had tried to actually manage her operatively for a few days, but she couldn't even lie on her buttocks. She was lying with her tummy. So that's one indication telling you that the patient had got actually sacral fracture. So fixed from the front, went in and deployed a screw at the back. It was a little bit late, didn't get a perfect reduction of the sacral fracture, but she had done neurologic fallout, so fixed it in situ, and she did quite well. And there she is several months later, no pain. Actually, she presented 1 year later with a baby. So I think I'll try and stop there, and probably we can begin some, some discussion.
Thank you, Dr. Muchiri, for that presentation.
Yeah.
That's a beautiful presentation, Dr. Muchiri. We do know that pelvic fractures can be quite difficult to manage, and we are happy that even the very complex ones can be managed right here. So, Dr. Muchiri, can you see some of the comments in the chat? Dr. Muchiri.
Let me get them right away.
Can you see where they are?
Let me get to them.
We can't hear you very well, Dr. Muchiri.
Yes, sorry, I'm here. I'm trying to get to it.
Oh, that's fine.
Sorry.
If you get to it, you can answer. There are not too many.
Oh, very good. Yes, I was struggling to share. Yeah, so
That's fine.
Sorry, my apologies that I had to move very, very fast. It's
That's fine.
Period is 30 minutes. So somebody is asking me, is there a role of conservative management for Morel Lavalley lesion? I don't think so. You know, moderate value lesions, they are very interesting. The other day, actually, I saw one that was chronic. The patient presented 8 months later with this swelling that refused to go. And interesting enough, for those kind of patients, you still need to go and drain them. He was lucky that he did not get infected. So actually, we needed to go and drain it and actually do what are called kilting stitches to be able actually to bring the subcutaneous tissue and suture it, you know, to the fascia, because they tend to keep recurring. So I don't think there's a role of it. I think somehow they have to be drained. Obviously, you know, like in medicine, some things will fall through, for lack of a better word, through the cracks and heal without any intervention. But by and large, if you find it, I don't think you should leave it. Okay, the other question is
Yes.
any challenge in the obese patients? Definitely, yes. In the obese patients, you'll find it's a huge challenge, you know, especially to do open, you know, open procedures of the pelvis, huh? And that is where now the percutaneous techniques come in, and that's very, very important. I think the key thing is, first thing is to understand the anatomy, and once you understand the anatomy, it's easy to be able to go in and minimally, you know, reduce. You can use a lot of joysticks. Like I use a lot of joysticks. Like I can put a pin in one fragment just to help me maneuver it and help me reduce, at the same time be able to deploy a lot of percutaneous screws. So it's quite a challenge for these patients, but if you're able to do a lot of percutaneous fixations, then I think it will be of much help. How do the different patterns vary?
Yeah, thank you, Dr. Muchiri.
Sorry, yeah, can I go ahead with the questions, with the answering?
Yeah, please go on. Yeah, please go on. Please go on.
Yeah.
Please go on.
Yeah, so another question is, how do the different patterns vary in terms of functional outcome? That's a good question. We didn't go into it. This is easily a very long discussion in terms of the various outcomes. But one of the things I think I need to bring, we have always emphasized that anterior posterior compression has worse outcomes, and that is because of the hemodynamic instability. But I think, let me bring to your attention that lateral compression injury patients have more head injuries, have more visceral injuries. So always remember that. So you'll see a lot of lateral compression patients because they're hit from the side, and a good number of them are rollovers. Remember, they have got actually a good number of injuries, even if they're not hemodynamically unstable. So always look for those injuries. So it's very, very key. We talked about the degree of displacement determines also the level of neurologic fallout in sacral injuries. Okay, obviously there's a very important question that has come in, and that's very, very important to discuss. We didn't get time to discuss that, and that is the timing of pelvic ORIF. You know, when do you say that I cannot try this, you know, and all that? It's tough. I think, for lack of a better word, I think we need to write our own books, because I've taken care of some injuries that are 3 weeks out. This week actually we were doing a case. It took us a little bit long, but we fixed it. It was 3 weeks out. There's another time we fixed a patient that was like a month out, and obviously they become very difficult. They're not easy. They're not a walk in the park. You never get sometimes those optimal fixations. But you know what I've come to realize with pelvic injuries? If by the time the 3rd, 4th week, patient has come late, still has symptoms, can't stand, and you can see there's potential for displacement. One of the things I came to realize, you may never get best, but you'll get good. The most important thing is stability. If you accord stability to that patient's pelvis, they'll be very happy. Takes away pain, mobilize them early. That's one thing I usually say. So that's very key. Optimal timing for me is between 7 and 14 days. If I get them just within the first week, once they have been stabilized hemodynamically, they've been transfused, other injuries have been taken care of, I think 7 to 14 days is a good time to catch them actually. So you're easy to reduce. How fast do you want to mobilize your patients? That's very interesting. It depends on the injury, but a good number of my patients, especially those who actually on the side that they don't have the sacroiliac injury, I always put full weight bearing. On the side that they have got a sacroiliac disruption or sacral fracture, I always actually do partial weight bearing. So they start moving almost the following day. Unless somebody has got other injuries, but a good number of my patients, they're up and walking. The key thing is partial weight bearing or full weight bearing, depending on which side has got the injury. So who does for you the CM imaging? Or is it self or technician, and do you use more than one CM? That's a very good question. That's a whole lot of discussion. I just moved from a place where I was being taken care of very well, and I moved to the government setting. I was in Kijabe for some time, so we had a good system of getting who to do it and all that. So when I came out here, I was very lucky. We were able to get a very nice radiology student. She's always there. She's ready to do it and learn. Sometimes they're not. You have to the nurses and tell them. So I think it basically behooves us as the surgeons to be able to understand how to use a CM. So it's very important. So I think you really need to know how to use a CM so that you can teach anybody. You can teach a scrap tech, whoever it is. Like in Kijabe, it was scrap tech. We didn't have radiology support at all. So we trained them, they knew how to use it, and actually they could help us. So by and large, you can actually train somebody and they help you do that. Obviously, there's going to be a lot of radiation initially. Ensure you get some good thyroid shields. If you're able to get goggles with lead, it's very, very important, and get good jackets. So it's very important. So a lot of these percutaneous techniques, initially, you'll shoot a lot. And so to protect yourself, one, get a good CM, ensure Radiation Protection Board has checked it, and because it's going to expose you to some radiation. So that's key. Have you had any incidents of iliac wing non-union in case of fragility fracture of the iliac wing? No, I have not, and not yet. Probably it's out there, but I don't know. I don't know. I've not gotten any. Do partially threaded screws pose a risk of L5 nerve root entrapment in comminuted sacral fractures due to the compression? I think that's a very good question, because what you have to realize is to get the right corridor. L5 sits in front of the sacrum. So L5, by the time it's in the sacrum, it's sitting right in front. As long as you're always deep to the sacrum, to S1, you will never hit L5. L5 is going to be hit unless you are in the ilium, you got out, you hit L5, then you went back to the sacropromontory. Then you will hit L5. But as long as you use the technique, chances are you're not likely to hit L5. So the threads usually are not a problem. If you're trying to hug the anterior cortex, ensure you hug it, but you don't penetrate through the cortex of the sacrum, right there in the sacroala. So that's a very good question about L5. So what's your experience in elderly with osteoporosis and pelvic? Yes, sorry.
Yeah.
Can I go ahead and finish?
So I wanted to say that you jumped that question.
Okay, okay.
Yes, yes, I wanted to remind you that question, yes.
Oh, you want me to answer that question?
Yes, I wanted to remind you that you jumped that question. So carry on.
Oh, yes, thank you. What's your experience in elderly with osteoporosis with pelvic fractures? I think that's a very good question. One of the things that's good about the ilium is that, about the pelvis, is a good blood supply. So I think if you bring, the fragments together, chances are it's going to heal very fast. So one of the things I've realized with the elderly patients is that if it's possible, I try to avoid a lot of dissection. So I try to do a lot of percutaneous whenever possible. But by and large, because of the specialized cancellous bone, this accepular region, you tend to get away, a lot, especially if you use a lot of plates. So I find myself, if at all something is comminuted and all that, I can't do percutaneous, I'm always going to bridge and put plates across. But the key thing in old people, I try to dissect less. If I can, use a lot of joysticks, reduce percutaneous techniques. They tend to do well. So I've not had a problem with the, with the very, very soft bones. I think the key thing is to understand just, how to bring the fragments together and hold them in place. I have to mention this, and that's very, very important in osteoporosis. When you're putting your sacroiliac screw, I think it's very important to remember that you try and aim to the top of S1 and anterior of S1. So try not to stay in the center of the sacrum. because there is very soft bone there, especially in old people. The screw will go and you keep turning and you're never happy. But when you go near the cortex of L5, either cephalad or anterior to it, you start hugging that cortex with your screw, you'll be very happy. It will give you a very good hold. So that's very, very important. I've always been prepared when I'm dealing with an old patient. I always just say, in the worst case scenario, I always have a bag of cement. I carry it around. So I think I've been carrying one around. I hope it does not expire. But I'm always ready to do cement augmentation. Where I feel, wow, I'm not getting good thing. I just inject cement and probably let it hold, like what we've done in neck or femur fractures, just to augment our fixation. Yeah.
Dr. Muchiri, there was a question on whether there are times that you use fully threaded screws.
Oh, fully threaded screws. Very good question. Actually, we had a discussion with some members of the industry the other day, and sorry, I didn't, these slides were too many. I think we need to get an opportunity to discuss that. In transiliac screws, I have, several of those cases where you don't want to compress, especially fractures going through the neuroforamina. That is what we call the knee type 2 in the sacrum. You don't want to compress. You want just a positional, a sort of like screw, just to hold things. Then you need to use our fully threaded screw. Another thing is you're doing transiliac screws. You just want to go from one side all the way to the other one and just hold things in position. I think there is a good place for actually fully threaded screws. They are not. I've been trying to push guys in the industry be able to order that. Obviously, they're not used very much, so for them it's almost like dead stock. So they may not be able to stock them much, but I think there's room for them, although not very, very frequent, like partially threaded.
Thank you, Dr. Muchiri. I think that's